Pressure. A pressure ulcer is defined as localized damage to the skin and underlying soft tissue. Increased risk factors include persons with bony prominences, multiple comorbidities, condition of the tissue, medical devices that are in place, along with causes that continue to be researched. Pressure ulcers can be intact or an open ulcer, which can cause pain and possible infection. They are caused by prolonged or intense pressure or shearing. The clinic. Pressure ulcers are staged in 4 stages. Stage 1 is intact skin. It's a localized area of non-blanchable erythema, and it appears different in people that have a darker skin tone. Stage 2, it's when the wound bed is viable, pink or red, moist, and it may also have a serum-filled blister. Adipose tissue and deeper tissue are not visible. Granulation tissue, slough, and eschar are not present in this stage. Stage 3, full thickness skin loss. Adipose tissue is visible in the ulcer, granulation tissue, and epibole, which are the rolled wound edges, are also present. Slough and eschar may be visible. There may be undermining and tunneling in the wound. Fascia, muscle, tendon, ligament, cartilage, and/or bones are not exposed. Stage 4, full thickness skin and tissue loss. Exposed or directly palpable fascia, muscle, tissue, tendon, ligament, cartilage, or bone in the ulcer. Slough or eschar may be visible. Epibole, undermining, and/or tunneling are often. An unstageable pressure injury is obscured full thickness skin and tissue loss. The extent of tissue damage within the ulcer cannot be confirmed due to the obstruction by slough or eschar. Once the slough or eschar is removed, the stage 3 or 4 pressure will be revealed. Pressure. Hospital. Supply.
How do we improve pressure ulcer rates? We improve pressure ulcer rates by evaluating skin integrity from head to toe, anterior and posterior surfaces, skin temperature, edema, change in tissue consistency, and checking for presence of pressure injuries upon admission, discharge, and at least once every shift. Checking for pressure ulcers should also be done upon any significant change of the patient's condition. Why are hospital-acquired pressure ulcers still occurring with prevention plans in place? Skin assessments are not being conducted as frequently as they should. A change in the patient's condition may happen rapidly. Lack of nutrition, dehydration, immobility, incontinence, and diabetes all contribute to increased risk of the formation of pressure ulcers. The Braden scale is used to score and determine if a patient is at risk for a pressure ulcer.
How do prophylactic dressings on hospitalized adults decrease the number of hospital-acquired pressure ulcers as opposed to those who did not use these interventions during at least 1 week's hospital stay?
The current standards for classifying, intervening, and measuring outcomes under Kaleida Health policy. Kaleida Health assesses patients upon admission, upon transfer from another unit, once each shift, and with change in patient condition, and upon discharge using the Braden scale for prediction pressure injury risk. We initiate and implement pressure injury prevention plan for all patients scoring at risk determined by the Braden scale of 18 or less for an adult. A prophylactic dressing such as a leave-in or polyurethane foam dressing may be applied to bony prominences for the prevention of pressure ulcers in anatomical areas frequently subjected to friction and shear. The prophylactic dressing is replaced every 2 to 3 days, or if it becomes damaged, displaced, loosened, or excessively moist. A provider's order is not needed unless undermining, tunneling, or large cavities that require gauze packing are present.
At ECMC, upon arrival, whether it's in the emergency room, a direct admit, or just a unit transfer, all patients are to receive a head-to-toe assessment. Each patient is also supposed to receive a head-to-toe assessment per shift, which is usually about 12 hours. All assessments are to be documented, and no order is needed to use a prophylactic dressing, but it is required for all patients with a Braden score of 15 or below. Dressings are applied without orders, but they still need to be changed every 72 hours or when soiled or displaced. Any open pressure injury or even a stage 1 that is non-blanchable need to be immediately reported to the physician. Leave-ins are available in all clean supply rooms, so it doesn't need to be patient-specific. It's encouraged to also teach the family and the patient about skin inspection, preventative measures, and the risk factors. When a patient is not able to turn and position themselves and need any help from the staff, we use what's called the Prevalon system. It's a pad that goes underneath them and makes it very easy to turn and position and slide a patient. We also have to assess bony prominences every 2 hours during our turning and positioning for any redness, warmth, blanching, just to make sure it's not turning into a pressure ulcer. This synthesis review is the systematic review of the use of prophylactic dressings in the prevention of pressure ulcers. The purpose of this review was to consider the evidence that supports the use of a prophylactic dressing for pressure ulcer prevention. We found that the use of prophylactic dressings in order to prevent pressure ulcers is extremely effective. It is much more effective when there's other preventative interventions in place. The use of prophylactic dressings and other pressure-reducing intervention plays a huge role in protection from shearing during weight redistribution. This review had 21 journals, all with positive results related to pressure ulcer prevention. All of these articles were chosen based on strict inclusion criteria. The benefit of the study is they found that the sacrum, the nose, and the heels all had positive results and had a reduced pressure ulcer occurrence with the use of prophylactic dressings and other preventative measures that were in place. A decrease in pressure ulcers increases patient satisfaction. The risks here, they only used 2 different types of dressings, and those were the only 2 that met the inclusion criteria in the 21 articles. This synthesis study was called the Prophylactic Use of Dressings for Pressure Ulcer Prevention in the Critical Care Unit. The purpose of the study was implementation of prevention strategies upon admission to eliminate pressure ulcers. So as soon as a patient got there, they wanted to improve the patient experiences and their outcomes. They wanted to improve teamwork and communication among the staff through huddles. What they found was that the use of prophylactic dressings and other interventions decreased pressure ulcer incidence from 19.9 per 1,000 patients to 0.84 per 1,000 patients in 2014. They had a total of 310 pressure ulcer-free days, and the staff was said to work more effectively and efficiently. This is important because decreasing pressure ulcer prevalence by making small changes will increase patient satisfactions and their overall health outcomes. If the staff can communicate better when in need of assistance for turning and positioning and during a report, patient outcomes will increase. It is proven through evidence that the use of prophylactic dressings for pressure ulcer prevention works. The use of staff huddles proved that it helped improve and promote positive communication with the staff. The benefit of the study is showing that the use of prophylactic dressings along with other pressure ulcer prevention strategies do contribute to the prevention of sacral and heel areas. A positive improvement on communication between staff during shift and the report is proven also. The weeks following the study, documentation compliance on skin assessments upon admission and per shift declined. There wasn't enough support on the unit to continue this change.
Synthesis Study 3. Prophylactic sacral dressing for pressure ulcer prevention in high-risk patients. A quantitative study. The purpose, findings, and relevance of this study. The purpose of the study was to assess whether treating high-risk patients with a prophylactic sacral dressing decreases the incidence of unit-acquired sacral pressure ulcers. The findings of the study found that after the sacral dressing began being used, the number of unit-acquired sacral pressure ulcers decreased by 3.4 to 7.6 per 1,000 patient days, depending on the unit. The relevance of the study supports the need for the use of prophylactic dressings to prevent hospital-acquired sacral pressure ulcers in patients deemed high risk for skin breakdown. Synthesis Study 4. Effectiveness and value of prophylactic 5-layer foam sacral dressings to prevent hospital-acquired pressure injuries in acute care hospitals, an observational cohort study. This is a quantitative study. The purpose, findings, and relevance of this study. The purpose of this study was to examine the effectiveness and value of prophylactic 5-layer foam sacral dressings to prevent hospital-acquired pressure injury rates in acute care settings. The findings of this study indicate that there was significant pressure injury rate reductions in the U.S. acute care hospitals between 2010 and 2015 were associated with the adoption of prophylactic 5-layer foam sacral dressings within a prevention protocol and changes to Medicare payment rules in 2014. The relevance of this study supports the use of prophylactic foam sacral dressings as an effective component of pressure injury prevention protocol for acute care hospitals to prevent hospital-acquired pressure ulcers.
The purpose of proposed changes include applying leave-in dressings to known areas of concerns on patients with Braden scales of 18 or less, to train the staff on the proper use of the Braden scale and how to properly identify the start of a pressure ulcer and the included risk factors. We want to continue to re-educate staff and test their knowledge yearly or anytime any new research on effective preventative measures is introduced. We need to complete the study is financial investment on prophylactic dressings such as a leave-in. We'll need adequate staff to provide initial training and continued education and an educated wound care team. This study will affect patients that are at an increased risk of pressure ulcer development, registered nurses, licensed practical nurses, the wound team, education or the in-service department, the team leaders on the floor while they help implement, and the hospital, the department that's in charge of the supply costs. The way they'll be affected is there will be a higher standard of care that will be delivered to the patients, a reduction of pressure ulcer prevalence, an increase in patient satisfaction with care. Nurses will receive continued education on pressure ulcers and the prevention, and the cost of proper pressure reduction dressings. We did a quantitative study in 3 public hospitals in Buffalo, New York. Included were the patients that were on any medical or surgical ward for 7 days. The pilot study was conducted over a period of 3 months. Out of 984 patients that were at risk for developing pressure ulcers, 821 of them met the inclusion criteria, 462 of them being men and 359 of them being women. We used convenience sampling to get our sample. Inclusion criteria included being 18 or older, having a Braden scale of 18 or less, being an inpatient for a duration of at least 1 week's time, skin assessment documentation recorded every 12 hours during the stay. Exclusion criteria included patients that were too unstable to receive a full body assessment every 12 hours, and patients who refused prophylactic dressing treatments. We will know that we have reached positive results if this study shows a decrease in pressure ulcers in hospitalized adults that are on medical or surgical wards during their hospital stay.
Implementation. How would we integrate this into practice? We would first start with a pilot test on a couple of chosen hospital units. We will then provide in-service training and education at the unit level, giving staff the tools and support needed to make the necessary changes and implement correctly. Addressing barriers and providing clear communication for all staff, as well as ensuring the staff knows the reasons behind the change, is also important. This will aid in staff members accepting the change. Evaluation. Evaluating the process and its outcomes. The The most important form of evaluating the process and outcome is the positive prevalent change in the rates of hospital-acquired pressure ulcer rates, which would be a decline. Positive feedback from staff members is another form of evaluating the process. Deciding to adapt, adopt, or reject the change. If results are trending in a prevalent and positive direction, we would adopt the practice and adapt to the change. If results are trending in a downward direction or have no significant change, we would most likely reject the change and begin further research. Integration: how changes are communicated to the stakeholders. Changes can be made through various communication methods, such as reports, faculty meetings, hospital or company-wide email, and intranet announcement. Maintenance: how will changes be integrated into policy procedure standards? Changes should be integrated into policy upon the decision to adopt the change. This should be completed by updating the policy and procedure in the hospital's manual, as well as distributing the new policy to all staff members. Management should follow up to ensure the new policy and procedures are being followed and implemented correctly. Continued monitoring and analyzation of structure, process, and outcome data. Receiving continued feedback from units, departments, and staff. Tracking changes of incidence and prevalence of hospital-acquired pressure ulcer rates, and distributing monthly reports hospital-wide of the hospital-acquired pressure ulcer rates. Dissemination of the results. Results should be communicated hospital-wide to all stakeholders, management, and staff. This should be completed through faculty and staff meetings, intranet, hospital-wide email, memos, as well as patient and family survey results.